Okay, hello, hello. All right, module 5. We are finally diving deep into hormone therapy. And remember that we talked about that there are other options. You don't have to go on hormone therapy. And, in this module, we'll talk about um, the dosing, like ways that you can administer hormone therapy and the dosing. But then in the next module, we'll talk more about the benefits and the risks. Okay, so you'll still don't give up, you're not done yet. All right. Well, of course, there has to be that disclosure that this course is not serving as medical advice. It's just for educational, informational purposes. And you should seek medical advice from your provider. And if you don't have one, see your primary care provider, see if they can refer you to someone, or you can go onto the Menopause Society website. They have a list of certified providers, but there's also plenty of local gynecologists that may be knowledgeable. Okay. All right. Oh, and I don't want to discount the fact that there are some newer online platforms that can be helpful, but I don't know how good they are with subtleties when people are having issues. Okay. So remember that our options, estrogen alone is an option for women who don't have a uterus. And progesterone alone is also an option. I kind of didn't really address that before, but sometimes especially in perimenopause, I may start someone just on progesterone to help. We did kind of talk about that, of how the estrogen level might stay up a little bit at first, and then the progesterone level drops a lot sooner. So I might go on progesterone alone, at least for a while, and that can help. Sometimes that progesterone may be the only thing someone needs. And then estrogen and progesterone together, which is the typical scenario for someone who has a uterus and is having perimenopausal or menopausal symptoms. And then testosterone, if estrogen does not improve certain problems like libido or even sometimes the brain fog or fatigue, then adding testosterone can be helpful in those patients. And then the vaginal estrogen options, which we did talk about before, very briefly, but we'll talk more about that. Okay, so basically when we're talking about estrogen administration, we're talking about either an oral, a transdermal route, or a vaginal route. So oral makes kind of sense. You take a pill. So in this scenario, you would take a separate estrogen pill. And then if you're also needing to be on progesterone, you have a separate progesterone. Okay, if you're taking an oral estrogen, they don't come, well, that's not totally true, but usually you'll take a separate progesterone if you want to be on a micronized progesterone. There are a couple of formulas here, like oral estrogen combined in the same pill with a progesterone. That would be Femhart. Technically, that's norethindrone acetate, so it's not actually micronized, not progesterone, it's a progestogen, but that would be Femhart. And then or another option for oral is a low-dose birth control pill, which we had discussed, like low estrogen, especially if you are perimenopausal, possibly still needing contraception, that would be an option. And of course, if someone's taking an oral estrogen and a separate progesterone, that progesterone could be, instead of an oral pill, that could be the Mirena or Liletta hormone releasing, progesterone releasing IUD. So that is one of those options here. Okay, so you got 3 oral options. And the advantage is it's convenient. A lot of women are used to taking pills. Take a pill a day. It's pretty easy to do. And the negative part is where kind of the reason we stay away from it, particularly if you're already in menopause, is that taking estrogen orally does increase your risk of thromboembolic events like a deep venous thrombosis or DVT in your leg, or pulmonary embolus, or a stroke. So venous thromboembolic events, VTE. And it also increases triglycerides by taking the oral estrogen. Why is that? Is because of something we call first pass effect or first pass liver metabolism. What that means is when you swallow a pill, it has to get absorbed and go somewhere. And from the stomach, the blood supply actually takes anything absorbed straight to the liver first. So it gets metabolized in the liver before it goes into the bigger blood vessels to go all over your body. And in the liver, the liver controls all the clotting factors. So the oral estrogen will interfere with those clotting factors and make more clotting inside your blood vessels. It doesn't mean you're going to have that happen to you. The risk is low, it's higher. So if we can avoid that risk, and in the Women's Health Initiative study, the risk was primarily in the first year on estrogen. So keep in mind that study, the women were older when they were starting hormones. So it's not really easily extrapolated to the patient population today that we usually prescribe hormones for, but it's something to keep in mind. I think I would also keep in mind that consider how low dose birth control pills we usually don't prescribe to someone who has high blood pressure. I probably also would avoid oral estrogen in someone who has high blood pressure, okay, or already has a problem with their cholesterol. Okay, transdermal estrogen. Dermal means skin. So it's going through your skin into your bloodstream. So we have patches, most common patch. I mean, we write for it as estradiol. The brand name is Vivel. There's gels called like a gel called Divigel, and there's a spray called Eva Mist. I will tell you the most OBGYNs who do a lot of OB and don't do a lot of menopause don't even know that there's anything but a patch, or don't even know that there's anything that's an FDA approved bioidentical formulation that's anything but the patch. So you need to know this information so that you can advocate for what you personally want. Okay. Now, as we were just talking about the oral estrogen going straight to the liver, these formulations, because they're going through your skin, usually the gel or spray you can put on your arm or you put it on your skin, maybe the inner thigh. The patches usually you put on your lower belly or lower back. They don't go directly through the liver, and so there's a lower chance of VTE, venous thromboembolic event. And the hormone levels also stay more stable. Let's think about what happens when you take a pill. Your pill you swallow, it peaks in your bloodstream and then it drops. Okay, and then the next day you take a new one. With a patch or gel, for whatever reason, the levels stay more stable. Okay. Now, this isn't considered transdermal, but transvaginal. But the fem ring is the only ring that's for the vagina that's intended for systemic estrogen. Okay, so this fem ring gets changed every 3 months, and you still need to be on a progesterone if you still have a uterus. So you might be still, maybe you'll have the hormone releasing IUD inside the uterus, and the fem ring in the vagina. It goes up to the top of the vagina usually, and you just have to change that every 3 months. Or you would have the fem ring in, and you would take the oral progesterone. Okay. Same with the patch. Let's say you're using the patch for your estrogen, and then you're maybe taking the progesterone every night at bedtime. Remember, the progesterone we talked about helps with sleep. It crosses the blood-brain barrier and actually goes to your sleep center. Same with the gel. The gel is a daily. The patch comes in 2 formulations. The patches, you can do a once a week patch, or you can do a twice a week patch. The twice a week patches tend to be smaller, and so it seems to be what more people want, and maybe the levels stay more stable. The once a week patch is a little bit bigger, but you only have to remember to do it once a week. So it does take, sometimes it takes a while to get used to changing a patch twice a week. But again, the hormone levels, sometimes I hear complaints about that last day, maybe that feels like the hormone levels are dropping. Okay. The gel is once a day. and the mist is once a day. And the mist comes in 2 different doses. The gel comes in several doses. So those are the positives. I want to mention something else about the patches because this is interesting. So there is one formulation of patches called the Combi patch that has estrogen and a progestogen. It's not progesterone, it's norethindrone acetate in the patch. Okay, we kind of talked about like micronized progesterone seems to do a better job of going and helping with sleep and crossing into the brain, and it doesn't have as much of an estrogen effect. And using micronized progesterone doesn't increase, breast cancer risk and other risks. So it seems to be the favored, but this might be something that someone needs. Maybe you just can't deal with taking a separate pill and using a patch. And so there is Combi patch. It comes in 2 doses, one with a lower amount of progesterone, one with a higher amount of progesterone, and 1 dose of estrogen, so estradiol. So it has the bioidentical estradiol, but norethindrone acetate is not considered bioidentical. But you still get that combination. That's why it's called Combi patch. So it's the only one that's like that. Something I just realized I also forgot to tell you about when we talked about estrogen, oral estrogen. Okay, there is one pill on the market that has testosterone that is approved for women. It's not separate testosterone. It's an estrogen plus testosterone pill called Estra Test, and that comes in 2 different doses. So I think if someone is, past if I were putting someone on hormones, the first year, again, I usually try to avoid oral estrogen. So let's say I have a patient who, after 6 months of being on transdermal estrogen, and she's on a progesterone or maybe not. Let's just forget whether she's had a hysterectomy or not. She's on on transdermal estrogen, and after 6 months, she's feeling the libido still isn't good, and she really wants to try some testosterone. I could, maybe first start her on a compounded testosterone, which I can kind of gauge the dose, or first try her on Testim, which is the FDA approved formulation for men. And then if we seem to be okay, we kind of got the dosing and we have an idea of about how much she needs to not have side effects and feel optimal, maybe then we could switch her over to Estra Test, and that comes in 2 different doses, and that's an estrogen with testosterone in 1 pill. So that is an option for women. I have very few patients I've ever prescribed it for, but they were the right fit for this medication. Okay. So we talked about the transdermal estrogen. Let's talk about vaginal estrogen. Why do you need vaginal estrogen? Again, not every woman has significant genitourinary symptoms, GSM, genitourinary syndrome of menopause. Not every woman has a lot of dryness. Maybe the dryness, okay, it's not so great, but you're able to use some lubricant and it's fine. Maybe you're not having UTIs, but you go on the transdermal or oral estrogen, and these symptoms haven't improved. So those patients might then decide, okay, I would like to be on a vaginal estrogen. Or maybe you came in and you saw your provider and the tissue just looked so dry. Maybe you're not even having intercourse, and so it wasn't even bothering you. But if we don't get that tissue healthy, meaning stretchy vaginal mucosa, well estrogenized, well vascularized. So remember, estrogen makes the vagina, improves the blood supply so that everything is stretchier and healthier, and improves the microbiome in the vagina and the strength of the urethra to keep bacteria out. if we don't treat these symptoms, if someone, not even symptoms, signs, if we don't treat that, even if you don't have symptoms, it puts you at a higher risk later for having urinary tract infections that and other potential things like just itching and irritation down there, but UTIs that sometimes are not diagnosed in their early stages. So, not to be crazy and scary, but it's not uncommon for elderly women to develop confusion when the problem that they've developed is actually a urinary tract infection. So presenting to the doctor with confusion and you get diagnosed with a UTI, and sometimes that's already in your bloodstream, you have to be admitted to the hospital. So it can be scary. So using a vaginal estrogen if you're not on any other estrogen, or using a vaginal estrogen if there's still signs of vulvovaginal atrophy, which is what we used to call it, genitourinary syndrome of menopause. If there's signs of that, even if you're on an estrogen systemically, or you're not going to take estrogen systemically, then vaginal estrogen is still important to use. Okay. And so let's talk about the formulations. There's the cream, estradiol cream, which usually when we start you on it, we start you on it every night for a week. And then after that, you back off and use it twice a week. Typically, some patients have to use it 3 times a week for symptom relief. And usually it's just there's an applicator and you insert the cream into the vagina. I usually recommend taking a little bit more and just rubbing it on the outside on the vulva, okay, and in the opening to the vagina. So, and that's something, again, you start on it, you're going to use it for your lifetime. Even when you're older, you're in a nursing home and all that stuff, you want them to continue using it, all the estrogens. So the advantage of the cream is that if you do need some on the outside, even like sometimes you just need it, you need that extra estrogen. The estrogen from the vagina is not actually getting to the outer area on the vulva. So that's the advantage of the cream. So you're not using 2 different things. The disadvantage of the cream is it can just get kind of messy. And so some people don't like it. So there's also a tablet. The brand is Vagifem. If you actually get the brand, okay, all right, so let me explain. Each pill comes on, I don't have a pen here, but each pill comes on an applicator already preloaded. So there's a little pill on one side and there's a button on the other side. So you insert this into the vagina, you press the button, and it releases the tablet in the vagina. So you're putting it up there. The brand Vagifem, I know that their applicators are made from cornstarch and they're biodegradable. I don't know that you can put it in your compost if you compost, because the city might not know what they are, but they are biodegradable. I don't know that the generic ones are. The company that makes the brand is a European company and they're very environmentally conscious. So I've had some patients who didn't like taking the tablets because they were taking the generic, and I don't think that the applicators, I think they're just plastic, and they didn't like that. But just to be aware, the tablets are nice because it's just cleaner. Okay. There's another tablet that usually we don't use in menopause, but it is called endometrin, and it's a little bit stronger. Usually it's used for fertility purposes, but it's a vaginal tablet. And then there's the vaginal ring called E-string, and that's changed every 3 months. I've had really positive experiences with that. The only thing is you have to be able to remove it from the vagina yourself. And sometimes when you get older, it can be harder to do that yourself. So, but the ring is a great option because then you're getting that estrogen to the vagina. And some of it is, any of these vaginal estrogens, some of it is going to get to the vulva. But a lot of times, at least even just at the beginning, the first few months when someone's starting, a little cream is helpful. The cream, thankfully, it used to be not available in generic, and it was quite expensive, and now it's available in generic. So that's the good news. Now, These creams are minimally absorbed into your bloodstream. Okay, minimal systemic absorption means minimally absorbed into your bloodstream. Therefore, there is no contraindication for using these unless you have an allergy to the estrogen itself or something else in the cream. Okay, that would be a contraindication, right? You don't use something you're allergic to. But if you've had whatever cancer, breast cancer, um, you've had even a DVT or PE, pulmonary embolus, or stroke or heart attack, doesn't matter. You're able to use the vaginal creams. You just want to use it per the recommendation, so twice a week typically. And I want to say that they just took all the warnings off of all the estrogen products. And particularly, this was one that really just didn't make sense because there were warnings about from studies related to oral estrogen on a vaginal estrogen product, and it just didn't relate. Okay, so when we talk about dosing, we try to start at the lowest effective dose. So let's say the highest dose for a patch, estradiol patch is 0.1. I'm not going to start someone just because your symptoms are just so horrible. That's not where we're going to start. So I might not start you on, the super, super low dose, but we're going to go with the lowest effective dose, lowest dose we think is going to work for you. And that could be a 0.05 or even 0.0375, which is lower than that. And then we're going to adjust it based on symptom relief and side effects. If you put someone on a higher dose, you might have more relief, but you might have more side effects that you're not going to want to continue to take hormones. So that's not the goal. What I will usually tell my patients is we'll start on a dose, and then I kind of want to hear back from them in about 2 months, 2 to 3 months. Let me know what your side effects are, what symptoms are still bothering you, and then I can decide on adjusting the dose if it's time to go up on the dose, or is it time to add the progesterone if they needed a progesterone. So this is totally individualized. And that's why it's really important to see someone who's experienced or someone who has really been mentored. I think that that's fine too, because sometimes, someone doesn't have a huge amount of experience themselves, but they've been getting a lot of mentoring or they have someone else in their clinic who is really experienced. And so they're able to go and just kind of touch base with them. So I think that's really important. So you may find, to pass the Menopause Society certification test, it doesn't really do a lot of specific case examples regarding which dose to start people on. So just because someone's certified doesn't mean they have that experience of how should I dose. It just means they're knowledgeable on the benefits, the side effects, the risks, and the options. But the dosing can sometimes be just experience and listening to the patient. That's a crazy idea, isn't it? Listening to the patient. Okay, so this is just a sample case that I want to throw out there. And obviously, each of you is going to have a different story, but I just thought it might be helpful. So Jennifer comes in and she's, we can say she's having a lot of perimenopausal symptoms. And she started on a 0.0375 dose of a patch, estradiol patch, on the day one. This got cut off. She still has a uterus, so the plan is to see how she's doing after 2 to 3 months. And at that time, many of her symptoms are resolved, which is great. But she's still struggling with insomnia. Night sweats are minimal, however. Not gone, but minimal. So she's still having a little bit of night sweats, but really the main problem is she keeps waking up. So at this point, she started on micronized progesterone, 100 milligrams, which is the lower dose, nightly. And this is known to improve sleep. And she needs to be on a progesterone to protect her endometrium, or the uterus, from the estrogen. So a month later, she reports back that she is sleeping much better and most of her symptoms are gone. Okay. Now, what if most of her symptoms had not been gone? Then, depending on which symptoms were still bothering her, I might have said, if it was just the insomnia, I might have said, let's go up on the progesterone to 200 a night. But if it was something else, whether it's even libido still is an issue, or joint aches, or um, anything else, irritability, I would have gone up on her estrogen. So you see how this is kind of, ooh, there's not like a cookie cutter. This is you yourself are an individual. So we're not going to be able to just, I'm not going to be able to tell you exactly what your provider should do for you. I think, the middle of the road estrogen patch dose is a 0.05. So that seems to be a very reasonable place to start. But if I have someone here's another example, but if I have someone who's older, let's say I have someone who is hitting close to that uh, 10-year mark after menopause, at which time we start to worry about whether they have already developed plaque in their arteries that could, uh, end up causing a heart attack or a stroke at some point, I would probably start them at a lower dose, especially if that patient wasn't having a lot of symptoms. So, what we're seeing now is besides all the patients who are coming to see us with symptoms of perimenopause and menopause, which there are an abundant different types of symptoms, which we talked about all the most common ones. But we're also seeing women who don't have any symptoms, who are learning about what we'll talk about in the next module, but they're learning about these benefits. And they're realizing I'm going to be living for another 30 years, and I want the best quality of life. And so we are starting a lot of women on hormones who don't have symptoms at all. And and in those patients, I wouldn't start on a high dose. I'd start on a lower, definitely this type of lower dose, like a 0.0375. So, okay. Well, we did talk about hormone therapy routes, including oral, transdermal, vaginal. We talked about all sorts of different formulations that are out there, and how that they impact the absorption, metabolism, and then generally start at the lowest effective dose. Lowest effective dose is not necessarily the lowest dose out there, right? Lowest effective dose is the lowest dose we think is going to work for the patient, and titrate to symptoms. Okay. See you for our next module, which is, oh, exciting. See you in a sec.